I got sick in January, right? I mean, I can even pinpoint 9th of January 2025, I got sick. Went to a GP. She quite quickly said, yeah, there's some antibiotics. You got flu, go get better. Took 7-day course of antibiotics, cortisone, all of those things didn't get better.
The base of this condition is severe systemic inflammation.
So the next steps, as I understand it, is we're going to do the aspirin challenge in order to pretty much discover, is there any reaction to that?
A lot of these things are also heterogeneous. Certain population groups struggle more than other population groups. This was not a condition known in Southeast Asia. This is not something that they struggle with. In the last 20 years, it's been picking up.
Greetings and welcome to Just Speak, the Shaun podcast. Today is an interesting one. If you follow us or if you've seen the reel we put out a little while ago, I was talking about me being sick and how just for some reason I'm not getting better, and it's now something that we've discovered is chronic. So as promised, I've brought my doctor in. And we are joined today by Dr Marinda McDonald, who is a South African medical doctor and specialist in allergy care. She is the founder of the Allergy Clinic in Randburg, and she has formal qualifications in allergies. I think it's a diploma in allergies, a certificate in allergies from the University of Southampton. So you'll correct me, madam, if I'm wrong in any of these things, but welcome.
Thank you very much. Thanks for having me.
Yeah, thanks so much for doing this. Like I explained, it's just one of the things we're doing with this platform, and you are like episode 2, so we're literally just going right in on this. And after many months of delaying it because of my health, I realized that we just can't delay anymore, especially when it was confirmed chronic. So we said, we just got to lean into it. You know, in our business, it's the show must go on. And so we're here. We're doing it despite the fact that 15 minutes ago I was clearing my sinuses of all sorts of things. But thank you so much for coming. And am I right? Is my research right that it's the way it's explained is like GP generally, but specializing now or going into allergy specialties?
Yes. So when I started in allergy many years ago, there was no formal qualification. I then did a diploma, and subsequent to that, I did the certificate. If you want to be an allergologist today, you have to be a pulmonologist, a pediatrician or a family physician. So you have to have a postgraduate, and then you do the certificate.
Okay.
So I kind of did the certificate. I was already in private practice for a long time, practicing allergies. So, you'd call me a GP allergist.
Nice. Yeah, because I see you went to University of Pretoria.
Yes.
Yeah, University of Pretoria. And then you obviously got really deep with the specialties from the different universities and whatnot. So that is cool. So credible is what we're trying to establish. And I think, I must say, every specialist I've seen, and I'll get a little bit into just the history of how we got here, but every specialist I've seen, and there's ones that have really known that I'm coming to you and that now I'm under your care, just high flying marks. Everybody's just very, very... supportive of the fact that you are the leading. And I think, I've also heard that people struggle to get in with you because of how busy you are with all that.
Yeah, unfortunately, it's because, as you've seen, we take a long time per consultation. So it's not a 15-minute quick in and out. It's an hour each time. The time is quite limited.
Amazing. All right, so before we get to my story, I thought we'll just spend a few minutes just talking about allergies in general, because obviously there's so many types of allergies and people get all sorts of allergies. And I was wondering, is there any... talk us a little bit about the broad strokes of allergies. And then is there anything that's like particularly dominant in the world of allergies that maybe you focus on? Or is your experience in allergies as knowledgeable as it is broad?
So allergies it's a very exciting field. And it certainly in the last 10, 15 years, the knowledge has just exploded exponentially. So something that was true 10 years ago might not be true today. Mm-hmm. And so we are expanding our knowledge very, very rapidly. So I'm not in a privileged position like in certain countries. When I go to international meetings, they'll say to me, so what do you specialize in? Or if I go to a rhinology meeting, they would ask me if I only do rhinology, and then I'd say, no, I do food allergies, I do drug allergies. Because we are so few people managing allergies, we kind of have to be a generalist specialist.
Yeah, makes sense.
And so I do anything from medication allergies, pediatric food allergies, eczema, asthma. I have had the privilege to work with great ear, nose and throat surgeons, and they kind of threw me into this chronic rhinosinusitis. I'm a member of the Euphoria. They've got an advisory panel that, which is a European patient advocacy group, which meets every 2 years, so which I'm a member of, which really also their mandate is to educate around patients. So I've had the privilege of doing a bit of everything, and then I've got a big environmental allergy practice, meaning I do desensitization to environmental allergies, which is where we met many moons ago. And so it is a very broad range of subjects that I do address.
Yeah. You mentioned the pediatric thing catches me, obviously, as a father especially. And I think with parents, with kids getting or having food allergies so early on, how does that even work? Like parents obviously freak out when something goes wrong and then they find themselves with you. How do you test kids and get down to the food allergy of it all?
So it's again, that's one of the great emerging fields, is that my children are 18 and 20, and when they were born, we avoided all food allergens. In 2015, a landmark study came out called the LEAP study that indicated that we develop food allergies through our skin through eczema, so uncontrolled eczema in infancy, basically the first year of life.
Yeah.
And if we give children what they could be allergic to, we can prevent food allergies by 85%.
Oh, wow.
So today it's the complete opposite.
Yeah.
So we kind of advise that between 4 and 6 months, we start introducing allergenic solids. And we, even if a child is allergic in that age group or in any age group, we test them, and then we can desensitize them and we can give them the food. And it feels absolutely counterintuitive, but the younger they are, it's like a piece of clay you can mold.
Yeah.
It's beautiful. So whereas an adult, there's limited data on adults, there's more data on children and on infants. But we started with the older age group of child, and as time has progressed, we've moved to infants. And certainly in my clinical practice, when I have a baby with a peanut allergy at 6 months, if the parents opt to desensitize or do oral immunotherapy, within 2 to 3 years, the child can eat 24 peanuts.
Wow.
So it's incredible what
I think that's fascinating and really encouraging for parents, I suppose, if you're willing to go the route. And again, you talked about the data being limited on adults. I think the data exists here because like you said, 10 plus more years ago, you and I first met, when I had developed in my adult years an allergy that, I was eating seafood. If I eat a prawn or if I eat crab, whatever, shellfish, I was breaking out into hives and having, I remember one time my lip went out, and that's how I got to you. And you proposed that desensitization, which, I love seafood so much, and I wasn't willing to quit it forever. So we said, let's go. And it worked. Since that, 3 years, whatever we spent together doing it, I was able to, and I'm still able to eat seafood. Yeah. So I think if you're willing to take the chance of it all, but I guess parents are also nervous, right? Because the baby, now you don't know how to really make that call. Give them comfort?
I think the big thing about allergy is finding somebody that can diagnose you accurately and then manage you. And in infants, it's interesting, their severe allergic reactions are much less severe than adult severe reactions.
Okay.
So even if you have a peanut allergy in infancy or as a young child, it's much less severe. So it's just like all of us, we get set in our ways. So your immune system gets set in its way. Mm-hmm. So while we can still mold it, it's like a piece of clay you give me. So if you give me a wet piece of clay, we can make a beautiful sculpture or piece of pottery from it. But as it's left out in the sun to dry, it becomes more hard. And sometimes you have to break down a bit and then build it up again. And it is possible to, just as long as it's not been baked, we can do it.
There is some hope.
Yes.
Yeah, because like I say, I can imagine parents are like, you know what, we're not taking a chance here and, like, you know, avoid it. But I also, you know, I had developed a horrible allergy to dogs. Maybe cats as well. I don't really like cats, so I'm never really around them. But we had 2 Pekingese dogs that when they first came to us probably 14, 15 years ago, they were like our dogs, right? And
Yeah.
so we're like very intimate with them, like playful. They were in the bed, all of that. And then some point I developed an allergy, and then I had to like separate from them. So they lived with my in-laws, and I obviously was just staying away. And it was heartbreaking because even the animal had grown the attachment that whenever I went to visit, you could see that she'd still draw to me. And I'd put myself through that moment of comforting her, whatever, but I'd struggle through it, you know. And my wife always said like, oh, you should push through and be with them and, you know, I suppose desensitized to that. But it's a really tough one to do, you know.
It's very interesting that continued exposure to pets.
Yeah.
In cats, we see that you can, there's a specific protein called FeLD1. So if you're allergic to that protein, you can become accustomed to your own cat. The same is partially true for dogs, but it's not to the same degree.
Yeah.
Whereas if we inject you with a cat or the dog, which we can do, then that we could take away the allergy. But just pushing through actually usually just makes you sicker.
Yeah, because now with what we're about to go into, which is my story, it's a little bit tricky because my kids are hounding to get a dog. And the answer is dad's allergic, so no. You know, so I don't know. I do not know that I am keen on the journey that is desensitizing to the dog.
That's actually relatively small. I mean, we can talk about that. We didn't test you for that this time round. We're more focused on your other problem, but it's an injection once a month for 3 to 5 years.
3 to 5 years. You see, I was with you
It's
for
a
3
little
years
marriage.
the last time. So you and I reunited. So coming to the specific story, and I certainly hope if anybody is watching this that we can help a little bit, because this, through meeting with you and diagnosing this problem, and also just some of you gave me the SAMTers Association to read up on and the different research elements of just understanding this, seems like it's quite common somewhat, but at the same time not quite known.
Yes.
So I think that's what we're needing to really address here. We want to establish what this is and just break it down, unpack it a little bit, so that if somebody's out there experiencing similar problems but hasn't gone and seen the right people to narrow it down. Because, so the story goes, I got sick in January, right? I mean, I can even pinpoint 9th of January 2025, I got sick. Went to a GP. She quite quickly said, yeah, there's some antibiotics. You got flu, go get better. Took 7-day course of antibiotics, cortisone, all of those things, didn't get better. Just really was struggling. And the way I was struggling, I almost thought COVID. I can't lie. And I've been showing off that I'm immune to COVID, because throughout the pandemic and the last 5 years, I've never been tested positive for COVID. So I always said, no, I'm immune to COVID. So, you know, now I'm like, shit, do I have COVID? And I'm like, okay. So I go and see a pulmonologist specialist physician who we trust and has helped my wife, helped my mom. So we know him, we trust him. And I go to him, and the day I'm with him, I've got this like hectic cough and I can't get a sentence out, and it's like, you know, breathing issues. And in full display of all these symptoms, the guy says to me, no, you've got acid reflux issues that's causing this. And it made no sense to my mind, because the symptoms and the diagnosis, so to speak, just didn't match, because I've been struggling with acid reflux for years and managing it with a gastroenterologist. And so, but I trust him, so I do what he says, which is double the medication that I usually take for the acid, you know, really suppress that and you'll get better. Funny enough, I do get a little bit better. So that obviously now makes you think, sure, this is it. And suddenly it recurs. It comes back by March. I'm like there. March, April, I'm sick again, and it's like not making sense. I get on text with him. We've been WhatsApping, keeping in touch about my symptoms. He sticks to this plan. He's like, no, just keep going, you'll be fine. Doesn't work out. And by June, I go and see my gastroenterologist, and she looks at me and she's like, hell no. I've seen acid give these kind of symptoms, but definitely not man down the way you look right now. And in that very moment, she calls the ENT in the same hospital and takes me straight to him. She's like, you got to see this guy now. And so we go downstairs and I see this guy and he's like, this is polyps. And he says, I'll, stake my whatever on it. This is polyps. Go downstairs, have a CT. We're going to confirm. Get the CT done. They confirm that there's polyps and he books me in for surgery. 1st of July, I have a surgery and I'm released the next day from the hospital. We think it's all going to be fine. He goes off on leave. Now, a week later, I am struggling, miserable, can't get by, man down. And I got to wait for him though. So anyway, I'm not going to now go see some other doctor and start a new case. I just wait it out. And a couple of weeks into July, when he gets back, I see him straight away. I'm infected. He finds infection. He puts me on some antibiotics and a whole lot of treatment. And then 5th of August, 1 month later, back in surgery for another clean out and whatnot. And those 2 surgeries later, a few weeks in, I'm still not getting better. Then comes up your name. It's like he put me with another pulmonologist specialist in the hospital and she did a lung function and a whole bunch of tests and they just could not pinpoint this thing and they sent me to you. And here we are. And within a few minutes of the conversation and taking you through everything I just said, you're like, nope, this is AERD. What is AERD and how are you so confident to go straight there?
Yes, so AERD is Aspirin-Exacerbated Respiratory Disease. The newer name is NERD, Non-Steroidal Exacerbated Respiratory Disease. The previous names were Vidal's triad or Samter's triad. So it goes by different names. Probably the reason I opted for that in terms of my diagnosis, because just we have not confirmed that with you.
Yeah.
So because you don't have a history of reacting to an anti-inflammatory because you don't take them because of your reflux.
Yeah.
So that's still, which we'll get to, which is due for you.
Yeah.
But I always try to speak from what happens in literature, but that part was maybe more from experience of the severity of your symptoms. Mm-hmm. Because the one step back diagnosis would be chronic rhinosinusitis with polyps. And AERD is a subgroup of chronic rhinosinusitis with polyps. And it's usually the more severe patients. So they have 3 things. They have an aspirin sensitivity or anti-inflammatory sensitivity. They have asthma and they have nasal polyps. So you've got 2 of them. You don't have the third one. Or we have not confirmed the third one of the aspirin hypersensitivity, which is something that we will still do. And when I'll follow your lead when we talk about that. So that was the problem of it, because it's also patients who, in the base of this condition is severe systemic inflammation. And you had the classic history of, I got a cold and I never got better in your 3rd and your 4th decade of life. And the delay to diagnosis of this is significant. So I see a lot of patients who might have 4, 5, 6 surgeries, and they say the surgeon didn't do it right. But it's not the surgeon didn't do it right. The surgeon just opens up the cavity in your sinuses. The inflammatory process keeps driving these polyps to grow. So it needs to be maintained with medication. So it's got nothing, the surgeon just basically removes the bony cavities so that we can administer medication accurately. And if you don't use the medication, you will end up back in surgery, unfortunately.
Yeah, and you say I've got 2 of the 3, and one of the 2 would have been the asthma. And I've struggled to even receive that. I'm still not convinced about the asthma, because everything I understand about asthma, I don't feel I have in symptom terms. So why would we be talking asthma with me?
So asthma is diagnosed in terms of airway reversibility. Airway reversibility is, if you think of your lungs, you've got that little bag of alveoli, and there's muscle. And that muscle, there's two parts to asthma. The classic one that we think of is the child at school with a blue
with
pump.
the pump and the
that
wheezy.
sits and he can't run on the rugby field. And that's just the acute bronchoconstriction. So that's the acute attack. Mm-hmm. But there's long-term inflammation underlying. So exercise-induced asthma is actually, you can have chronic asthma and exercise-induced asthma, but you can have the chronic inflammation and have relatively mild attacks or no. And in this condition of AERD, it's a systemic airway inflammation. So it's from your nose to the ends of your lungs that this inflammation happens. And we measure that by a white blood cell called an eosinophil. Eosinophil is a specific type of white blood cell. These are those, I've got that slide I showed you with the
Darth Vader
cells. And they literally are. They control the supply chain, and they release the chemicals that matures them, that attracts them, and they just keep on procreating these cells. And that's one of the biggest problems you've got there.
Yeah, I called it the Agent Smith because of that replication thing you spoke about, that nothing needs to invite them back now. They're just there making more of themselves.
Absolutely. That's what they do. And that's what makes it so resistant to treatment, because the moment you skip one dose of medication, you feel it. Whereas a lot of mild to moderate asthmatics, if I have a bit of a grass allergy, I have a bit of asthma, now and again I'll skip my pump and I'll be okay. But with this condition, it's definitely on the more severe. You skip a dose of medication, you're fully aware of it.
Yeah, and I found that and I'm rinsing twice a day. And if for whatever reason I'm tired, whatever end of day, and I'm just don't feel like that saga, I might skip it. And then the next day I see just the way the mucus appears, just the general sense of self is very much like, oh, that skip made a difference. And if you're consistent with it for a while, then it's clear and it's pretty much, a matter of course.
It's much better control. So maybe we can just explain what rinsing is. Rinsing is a saline. Saline is just salt water.
Yeah.
That is in a plastic bottle. And you take boiled water that's cooled down, put it in the bottle, take a saline sachet, add in. Some of them have xylitol in, some have surfactant in, depends on the manufacturer. In your case, we're adding cortisone in. You stand over the basin and you rinse, and it all comes out, and it rinse, and it all comes out. It does 4 things. It removes pollens, it removes pollutants, it helps to reset the biome of your airway, which I'm sure we'll talk about later. In other words, remove pathological bacteria, and then it's an amazing delivery device for that medication right up to places where your nose spray normally can't reach.
Yeah, no, and I definitely want to talk a little bit about the treatment and my life going forward. But before we get there, I just wanted to say, so the next steps, as I understand it, is we're going to do the aspirin challenge in order to pretty much discover, is there any reaction to that, and confirm this diagnosis.
Yes, correct.
Yeah.
So at the moment, your diagnosis would be chronic rhinosinusitis with polyps, and then with a question mark, is this the AERD or the NERD? There is a blood test that we could do. Unfortunately, the blood test is variable in its results. So the gold standard is a history. So if you tell me I take aspirin and I have an allergic reaction, then we don't need to go and do this thing called an aspirin challenge. But in your case, what we're going to do is we're going to do an aspirin challenge and possibly convert it to aspirin desensitization. And the two are distinct entities, but we combine them just to be practical. But the question is are you sensitive to aspirin? And it's not the aspirin that causes the disease.
Yeah.
It's a defective, it's multifactorial. And in the case of aspirin, there's an enzyme 5-lipoxygenase, where your cell membranes get broken down into 2 distinct chemicals. And when you take aspirin, you get an absolute overflow because your body can't process this. And you get an overflow of something called leukotrienes, which is a chemical that just overflows and you get this reaction. So we want to know, is that the case with you, or is your polyps not due to the aspirin, which is a diagnosis in itself? It's just, if it is the aspirin, then we can, as part of your treatment, desensitize you, which then would suppress the reactivity to this chronic inflammation. It's a way to treat you. So we are going to bring you in, and we will then give you incremental doses of aspirin. It's published protocols that we follow. We'll probably follow the European the ERK guidelines for the diagnosis of aspirin allergy, and every hour we give you a dose of aspirin, and we measure your lung capacity as we go along, and you very clearly can see you start to pour or your chest closes, and there is a possibility of, unfortunately, a severe allergic reaction, which we then will manage if that happens.
That's the fun part, hey? So how are you administering this aspirin?
You just drink it. Just normal. Can I say
Disprin.
that? Yes. It's just that it's very it's a big drama about one little tablet. So we take it, we put 10 mils of water, then I give you 30 milligrams, and then we wait an hour, then I incrementally increase it up to 1 tablet. And my patients are extremely brave, because it's people who are sick all the time. You come in for this procedure, we then give it to you, and then even if you have a severe reaction, then we give you medication to counteract it, and then we push through until you desensitize. This is the most dramatic desensitization we do. With other ones, it's not as difficult as this one. Like I was talking about peanut, etc. Those are much easier. This is just something, it's just highly managed. We won't put your life at risk, but it does take a bit of courage to sit and take something that potentially could make you sick.
And look, I mean, I don't have a problem with us talking names, particularly because we're not being in any way, defamatory about what it is. But what are some of the common medications that are just off the shelves and things, that has aspirin in it?
So the most common ones that people get wrong is Comprel. They forget that there's Comprel in. So because you can buy it at any store at Pick and Pay, part of your groceries, Comprel goes in, because it's a bit stronger than just paracetamol, than Panada. So Comprel, Corenza C, your Grandpa, and your over-the-counter cold and flu medications are the most common to have them in. Medlemon. Then, as part of the larger group of non-steroidal anti-inflammatories, that would then include, some patients can react to Myprodol, Mypate, Mybulin, Voltaren, Diclofam, all of those.
Wow. Now let me tell you something that's funny. I've been saying, why are we talking aspirin-exacerbated anything? I don't take aspirin, right? You just fired off stuff that I've taken.
You have. Have you taken
It's so funny because, and this is by no way, I'm not an expert, right? So please know the doctor sitting in the other chair there. I take a thing that I call the flu bomb.
Yes.
Whenever I get sick and in the early stages of feeling like a sore throat or something, I'll decide, no, it's time to flu bomb this thing. And I'll put a little bit of warm water into a cup, and in it I'll drop Lintagon, Corenza C, ACC, Immune, and all of this, I go nuclear on it. And I just down this thing. Makes me drowsy, puts me to sleep, and then I wake up feeling a little bit better. And so I swear by it, even though it's probably the worst thing ever, and we should stop that. But so many of what you said, like I said, because you said Corenza, I've taken Dicloflam or, Cataflam before, even for a headache sometimes, because it's fast acting. So clearly.
So there's the different people react differently. So sometimes I'll have a patient who has an anaphylactic reaction, meaning they get skin rashes, their chest closes, throat closing is not that common, but their asthma will get triggered. Some patients don't even realize so if you don't have the dramatic, like the one that anybody can diagnose, some patients, their lung capacity just drops. Or they just get extremely mucousy and they don't realize it. So they sleep through it, and then tomorrow morning they wake up and they just don't get better. And in this condition, sometimes we get these people who just don't get better. And it's possible that your flu bombs might have been contributing to this, just not getting better. So
you gotta love it.
When we test, you will see, because we have this moment in time where we are removing all of the noise, and we've got objective parameters that we can see. And if it is not that, then it's not that. And that's why we're doing the test, because it just takes all of the speculation out of it.
Yeah. If it is aspirin related, but I don't want to do the 3-year journey, what does that look like?
So this aspirin desensitization is the process. It was initially done by a crowd in America called the Scripps Clinics. And they published that this subgroup of patients with chronic rhinosinusitis did really well if you then give them the aspirin and you keep them. So part of aspirin desensitization is that day. So once you get to 1 aspirin, we then take you and we put you onto 2 twice a day, and that's it. So there's no updosing again. You just stay on it.
Okay.
So it's 75% effective to manage this condition.
Okay.
However, there's 2 big side effects. One is that your stomach can get quite irritated, and the other one is that if you're taking high dose aspirin, then you can get bleeds.
Yeah.
And one just needs to understand that if you do get a nosebleed, that you might need to just manage that a bit more aggressively. It sounds like a really terrible treatment, but I think just to qualify that patients with this condition this is not for the run-of-the-mill blocked nose or patient who says they've got sinus. This is really a severe form of sinus disease that's not just a normal nose spray and a quick rinse of saline resolves it. Your disease needs to justify this treatment. But in the patients that we've done it, and I've done in the last 20 years, I've done a fair amount. Patients do get they're significantly better for the period that they take the aspirin, and it gives them a much better quality of life. But it is the stomach that burns can be a problem later.
Well, it makes all the sense in the world that if something's going to be done right, I'm going to do it, right? Like, be the biggest possible case of this thing is me, of course. So in 3 years' time, once we've gone through this desensitization, and how would we know that we got to the price?
No, unfortunately, the difference now is between desensitization and immunotherapy. So desensitization is a temporary state,
okay,
whereas immunotherapy is a permanent state where we have changed your immune programming. Unfortunately, with this disease, we cannot reprogram your immune system. So you will be desensitized, meaning the day you stop taking the aspirin, your symptoms will return.
Okay. That sounds fun.
But you just won't have the damage of all the years of inflammation. So if you live with long-term inflammation in your lungs and in your sinuses, you can sit with a condition that we call remodeling of your asthma, and that leads to lung damage. So that remodeling will be significantly less. However, the moment you stop your aspirin, and I have patients who have to stop the aspirin because of a variety of reasons, there's one of 2 things we can do. We can restart the aspirin, or we kind of see what your symptoms are. There is now more modern medications called biologics available, and that would be a possibility. The problem with the biologics is the prohibitive cost. And also then because you've been well the time you've been on aspirin. So there is no end point to stopping the aspirin. It would be, if you're doing really well, we reduce. But if we go too low, then you lose your desensitization. So it's basically between 1 to 2 aspirins a day.
Yo. And so in keeping with the treatment side of this thing, so the nasal rinses, is that long-term now? Like, is that my life?
So definitely the saline rinses at least once a day makes a big difference.
Okay.
We then would use that in periods of I mean, I think you can very well attest to that. This condition is chronic inflammation carrying on, and then you have acute flare-ups.
Yeah.
And in those flare-ups, we need to give you something to suppress the inflammation. At the moment, what's available to us is either oral cortisone or topical cortisones. We had a discussion off air about the topical cortisones. You know, one takes into consideration then the mode of delivery, which would be a spray, or the one that we're using off-label, that is not, it's not registered for that, that we put into your rinse, or in your case, what we were doing is we were administering it directly just because you had had a flare, which is which is not something that we advise for everybody, and it's a very narrow scope there. But it's the choice of going on to an oral cortisone or that, and the oral cortisones. We are busy managing negative side effects of medications because unfortunately if you chose to do this the natural way, you would just end up being really, really sick. There is no natural alternative to this, managing this condition.
Because I told you the ENT was a little bit concerned about the fluid being directly administered.
Yes.
Given the cortisone levels and possible bleeding and things like that. But we discussed that.
So what happens is that the one that I'm giving you is got a 34% that gets absorbed systemically. And if you were to use that every day for a year, you would still get 16 milligram of systemic cortisone, and that's the concern. So the concern is of having high levels of external cortisones. We can develop diabetes, we can develop osteoporosis, we can develop diabetes. And so those factors are all taken into account. The direct application for now would be a short term to get you through that acute flare. And then what one does is 2 to 4 weeks later, we then revert back into the rinse. As soon as you're better with the rinsing, we then revert back to the nasal spray. And so it's always a case of stepping up. And then as soon as we've got control, we step you down. And that's where the surgery comes in, is that if you think of your face, your sinuses are your frontal sinuses, your ethmoids and your sphenoid sinuses, and then your maxillary ones that sits on the side of your nose. Now, when they go in the first time, they open up these maxillary sinuses and part of your ethmoids. Later on, if further surgery is required, they can open up all the way to your frontal sinuses, all the way up here, which is a very complicated surgery. But they don't do that for any other reason than to open up the cavity, so when one then puts medication in, that it gets easily in. Otherwise, it's like those little puzzles with a little ball running, and you have to kind of make the puzzle. And that's why I make you also, when you do this, you stand on your knees and you administer it, and you turn your head, and put it on your knees and you turn your head and lie back. And so it's to take the athleticism out of administering your medication, because that's how our sinuses weren't designed to drop medication in. They were designed to be filters.
Yeah, and I found that I'm also, exactly that. I'm turning my head and trying to feel that it's, keep it inside and let it absorb. And then often I find that this is one of the crazy parts, is an hour or two into the day, you bend over to pick up some keys that you dropped or something, and then out comes more fluid that's been sitting inside there.
I once had that. I was trying on shoes in a very fancy shop, and as I was tying the shoe, all this water came out of my nose.
And it's so horrible. It's just one of those crazy ones. And I don't know. It sounds like it's going to... And you're talking about the flare-ups, and I know when I saw you in your rooms the other day, we talked about how the household was sick. And one of my big frustrations that I'm finding is I don't know when me feeling man down is related to a flare-up of my condition versus picking up a viral something, within the house being sick. And you said, but average person being sick is times 10, and then me is times 1,000. How do I live this life, like knowing when I'm virally sick versus when I'm flared up?
I think, and I think I'm very funny, just by the way. So I always have this thing that I say it's much easier to be a doctor than to be a patient. And it's very easy for me to prescribe this, to send you to a website, to tell you. But the reality is that you're living with a low grade of inflammation all the time. And it makes your life quite unpredictable, especially if you want to be highly functioning. So you are always, am I going to be sick now? Am I going to, how long am I going to be sick? How long am I going to be off for? And the quality of life impairment studies, which is the doctor talk for how difficult this is to live with, in chronic rhinosinusitis is really significant. And it has condition that we describe as presenteeism, absenteeism. So absenteeism is easy. Presenteeism is I wake up and there's so much inflammation in my sinuses that you can just as well send me home. I'm at work, I get my tick if you work for a boss, but you're just not functioning. So it is very difficult. Over the years of managing this condition, I think I've seen people with a variety of different coping mechanisms. From my side, I do think the most important is to adhere to your medication and maybe a bit of Buddhism in terms of that the more we resist the suffering, the worse it is. And it's and I'm not being facetious, is that there is a certain level of suffering that I cannot get rid of with medication. So we can get you to be better, but there's no doubt that there's still, and if it's not the inflammation, it's the fact that you need to travel with a pharmacy. It's the fact that you need to now, if you're at a conference, you now need to wake up 15 minutes earlier to do your rinse. Otherwise, in 2 days' time, you're going to be sick.
Yes.
And that resistance to it makes it far more difficult. But I think it's very natural to go from a healthy person not needing anything to now being a sick person to have resistance to that, because it's not fair and it doesn't make sense. And so so I've seen people cope with by being absolutely informing themselves of the condition. I've seen amazing people being advocates for the condition. I've seen people who ignore it, and then 2 years later they're back with very severe disease because it's just not the phase of their life to accept it. I think I've seen, just like the human condition, a whole gambit of it. So for me, it is a journey of discovery. I think the exciting thing of it is, and that's why I say it's a journey of discovery, is that with these new medications, albeit that they're very expensive now, in preparing for this, I just went through some of the new literature, and it's literally now that with these medications, we found what works for certain conditions, and that's going to help us figure out what caused this. Because ultimately, I think the initial times when you came to me, you were, why? And I don't see that today in you. I think you've kind of come to the realization, maybe also in reading, is that we don't really know why.
Yeah.
We think it's your biome, we think it's viruses, we think it's bacteria, there's a whole lot of theories, but there's not the one why that we've established. And I think certainly in 10 years from now, our take on this will be very different, and kind of holding on for the ride and maybe seeing it as, and turning it into a positive, even the way that you are doing this now is part of it. Because my hope and also in coming here is that maybe we can, by focusing on this, we can help people in this journey that they hold on for when we have a much clearer why.
Better days ahead. I gotta say, and this wasn't even part of my prep, to be honest, and it maybe should have been, but I kind of focused very much on my journey. But it's time to focus on other people's journey. What's scaring me about what you're saying is it sounds like an expensive exercise. And while, some have medical aid, some have resources, whatever, what of the people that don't? What is there anything within the government hospital sphere that is like capable and equipped to help people that might have this that don't have resources and ability to pay medical bills?
You can see me getting goosebumps here because can I name a university?
I would say yes, as long as we're being just. I think that's our rule in this studio is.
So as part of these ENT colleagues that shaped my career, one of them had an absolute pivotal influence on my career and on many other ENT surgeons in the city's career. The University of Pretoria sends a fellow it's called rhinology. So a fellow it's an ENT surgeon. So they're a doctor, then they become an ENT surgeon, then they become a fellow. So if you're a fellow, it's a postgraduate qualification in what we call rhinology. Rhinology is your nose, but it's basically this skull-based surgery. So they do these surgeries that you were talking about. So for I now have my 4th fellow that rotates through my clinic for a year, and 2 of them have.
I met the one.
Yes, you did meet her. She's now back to KZN, and I've just had a new one that came. He's from a country in Africa. The other 2 were local doctors, and there's one of their consultants also worked with me. And what's incredible about this, you get to Belgium and they have multidisciplinary clinics. They've got physicians in the ENT clinic managing these patients. And this is like a flicker that we do have these people that are being trained. And they all know about aspirin desensitization. They might not have the resources at the moment to set up these clinics, but there's an awareness being created within the ENT community around this, the aspirin desensitization and the multidisciplinary approach of it. And certainly the people that I refer to, and I work with the pulmonologists, the ENTs, we don't have a clinic, but we have a multidisciplinary approach to it. And I think the awareness component is a big part of it. So it's very exciting, these ear, nose and throat surgeons, and that they are part of this process. So.
Okay. I hope so, man, because like I say, it's really tragic that, resources and privilege is where, there's a line that draws that. And having struggled with it the way I've been, I can't imagine, because you also spoke about the impact it has on your work and, like being present or absent or whatever the case is. And I've had a crap 2025. It's just been miserable. Like I said, we delayed the start of this podcast, which we had intended to do in the studio, had been ready to do for many months. But I couldn't. I just couldn't. I couldn't get up. Even now, like I wake up in the morning and I have a mild headache. It's not a severe headache, but I feel like this area of my sinuses, the upper, inside this area of my head is very much like sore and just I don't want to wake up in the morning. When I open my eyes for the first time and I got to get into the day, every day I got to like be there for a moment and just psych myself up that it's going to be okay. Because I don't want to now pop a pill to take care of that headache. I can't imagine that. Because when I do eventually get going and I go and do the rinse and have my shower and get into the day, I sort of catch up and I get okay, to manage the day. But those first moments is difficult. And the idea that somebody has to be forced to get up, get going, get to the taxi, get to somewhere for a job and just grind the day through. It just breaks my heart, really, is what it is,
I think if one keeps working at these things, and I'm the chairperson of a group called the Rhinitis Interest Group, which is a part of the Allergy Society of South Africa, and we have it's a joint group between allergy and ENT surgeons, and we also have a mandate to educate people. At the moment, we focused on allergies, and our next one is chronic rhinosinusitis, which is a big topic. It's like you've seen. The more you scratch, the less you understand, and the more you scratch. And sometimes I sound dogmatic, but it's just because there's a lot of research being done, but it's not in our core body of knowledge, because I was reading on the amount of patients with chronic rhinosinusitis, with polyps and asthma, and the amount of them that end up with aspirin disease. And every study you read, there's a different amount of percentages being given. So you'll notice me not talking about percentages because a lot of these things are also heterogeneous. Certain population groups struggle more than other population groups. This was not a condition known in Southeast Asia. This is not something that they struggle with. In the last 20 years, it's been picking up. So it's a very evolving condition, and that's why making people, doctors, aware of it is one of the bigger things that's going to shorten delay to diagnosis, which will then invariably improve quality of life.
And I think that for me is so important because as part of my research, I had reached out to doctors within our circle, you know, just in terms of friendships and relationships. And it's not very commonly known even at a doctor level, you know. I mean, one doctor even mentioned the allergologist, you know, just as a specialty of someone to go see, simply because they didn't have answers, you know, for you. And I did actually go and just get another opinion from a pediatric allergologist. And he actually said, you know, the whole aspirin thing and deferred almost in the opinion. So it's been an interesting journey, you know, and seeing like you said, this ever-evolving field of knowledge and information and how people need to. I mean, I'm just, because we have, I think if we didn't have the relationship we have and having known each other for as many years and all of that, I would have struggled a little bit more because now I have a trust relationship with you. So my trust of you is making me, you know, you talked about courage. I don't even think it's so much as courage, but trust, you know, just putting my situation in your hands and trusting you to take care of it and walk the journey. And I suppose the stupid part of me that's always been one to champion something, and now I've got a literal condition to champion with, you know, and sort of be the guinea pig for. So if I can add any information or whatever, I think we should, you know, and we'll definitely, I don't know, should we pick this up, or is there anything else we want to tackle in this conversation? Or should we do the aspirin challenge and maybe see if we want to do a follow-up?
I think that would be interesting, and to see if you decide to continue with a desensitization. In other words, after that day to continue on aspirin and see if you manage it, that we maybe 3 months after that have a chat and see how you're feeling, if it's made a difference or not. Yeah,
because I think if anybody does find value in this conversation, then some version of follow-up and reporting back might be necessary. And to the extent that whatever we can plan and do would add value to just the knowledge base and just the information that's out there, I think we should.
Yes, I think that would be very exciting.
So, so is there anything else in this conversation that you think we haven't touched on that we maybe should?
For me, I think if I can give the elevator pitch take-home message is that chronic rhinosinusitis can have many faces to it. It can just be the chronic rhinosinusitis. It can have a fungal component. It can have the aspirin component. It can have the allergy component on top of that. And that you find somebody that knows how to manage this, and that you then look for other resources, especially if you accept that not everybody knows about this condition, and that there is a lot of hope and there's a lot of things developing in this field. So that would be the take home for me.
Okay, then I think for me, just information. You sent me to SAMTA's Society as one of them. What we can maybe do is put up like an information board with just some websites and references or where people can go to. Is there any you want to mention just while we're in conversation?
I think the American one is, it's a Dr. Ladlow, and she manages the SAMTA Society website. Which is a very patient-friendly. I find it patient-friendly, very well, delineated. Euphoria is the European version of it. It's EUFORIA. They also have a patient advocacy group, which is you might be interested in joining. And they've got they do patient advocacy days. It's not just European; they kind of expanding out of Europe now, and the Allergy Society of South Africa, I think, might have some information on it, but I don't think to the same degree as those two sites. I think that would be a good place to start and to look at. My website has got some information on it, but I don't think that those two websites would be the kind
What's
of
your
the core.
website?
My website is allergydoc.co.za.
Okay, cool.
And although it's not strictly speaking an allergy, it is part of what we do.
Nice. Okay, well, thank you so much for coming and walking this road with us and giving this information. I think it was important. And I'm glad, even with whatever becomes our audience, I wanted this, if I'm sitting and having a conversation with another guest and I'm struggling the way I'm even struggling now. Yesterday, I had a scope down my nose that went into my throat. This morning, I woke up feeling that point that the impact was. So there's little physical challenges I'm having to sit in a conversation like this.
Yes.
And I decided, there's either quit and don't do it or just embrace it. And that's what this was also meant to do for us, is to just let people know that, hey, this guy is doing this. The show must go on. And that's what it looks like. So thank you so much for doing that for me.
It's a pleasure. And thanks for having me. And I look forward to seeing you for your aspirin challenge and our conversation afterwards.
All right. Thank you so much. This has been another one, the second one of Just Speak, the Shaun Naidoo podcast. I hope you enjoyed it. If you have any questions that you want us to maybe take to doctor and maybe get answered, we can always put out a different way of communicating some specific answers. And if you thought you had this kind of condition, maybe we can help you find out and get diagnosed and confirmed. So thank you for joining us, and see you on the next one.